Hello, welcome to Live Doctors. Today we have the pleasure of listening to Professor Raphael Mechoulam, who is Professor of Medicinal Chemistry at the Hebrew University in Jerusalem, Israel. Born in Bulgaria, Professor Mechoulam graduated in biochemistry from the Hebrew University. He's been Professor of Medicinal Chemistry since 1972, and his specialty is the use of cannabis in medical treatment. Throughout history, man has used plants and their chemicals for medical care. 50 years ago, Professor Mechoulam isolated and made the main active ingredient of cannabis, THC. Hello.
Hello.
If you can give us some idea of 50 years, the last 50 years in a nutshell, what you've been doing.
Well, we started our work, as you say, 50, even more years ago on cannabis. I'm a natural products chemist. I work with natural products.
Yeah.
And I was looking for natural products that have not been well evaluated and may possibly used as drugs or for biological purposes. And I was surprised to find out that while morphine had been isolated from opium 150 years previously, and cocaine had been isolated from coca leaves 100 years previously, cannabis, the active compound in cannabis, had never been isolated in pure form. People had tried that. Some excellent chemists had worked on that in the 30s. Lord Todd in England had worked on that. He got a Nobel Prize on something else, and people in the US worked. But the techniques apparently were not good enough, and while they knew more or less what the active compound or compounds is, they never got a pure compound. And so I thought it's a good idea to try to look at the chemistry. Now, that's not a theoretical problem. If the chemistry is not well known, the active compounds are not available, there can be no pharmacology, no biochemical research, and obviously no clinical research. So it's the first step in a longer stairs of research. So that's what we started doing. We got cannabis from the police. It turned out that we broke the law. We didn't know that. And the police broke the law, and we should have ended in prison. But we should have got...
Just as well you didn't.
Well, yes. Well, in a small country, you know, the Ministry of Health learned about our work and said, hey, you're breaking the law.
Yeah.
Now, in the US, I may have ended in prison, really. So I had to go to the Ministry of Health and said, look, I didn't know that you're in charge, not the police. Please forgive me. And they said, okay, don't forget. And since then, when I needed cannabis, I would go to the ministry, drink a cup of coffee with the people there. That happened sometimes to be my ex-students, and then take the piece of paper that they signed, take it to the police, and the police will give me hashish as much as I wanted. And I would take the hashish. At that time I didn't have a car, get onto a bus, and people would start looking, hey, what kind of smell do we have here? Anyway, we got the cannabis from the police and started looking at the contents of the specific compounds that are present in cannabis, and it turned out to be quite a mixture. We found about 12 compounds, even a little bit more, that have more or less the same structure, more or less the same family of compounds, but today we know that there are about 80 of them. Only 2 or 3 are major compounds, but only one turned out to be active. By active, we injected it, or a friend of ours injected it into monkeys and caused them kind of to lose energy, kind of go to sleep and so on. So we knew that THC is the active compound, which is strange, because you have about 80 compounds, more or less of the same structure, only one is psychoactive.
Right.
And we published that in 1964. We published on the structure of some of the additional compounds. There was very little interest at that time, essentially no interest. Right. We asked for a grant to go on. We had previously asked for a grant from NIH, and they said, no, this is not relevant to the US. Nobody uses marijuana here. Only in Mexico they do that. If you have something relevant, just contact us. Well, a year or two later, they came rushing to us. Apparently, a senator or somebody high up, his son had smoked pot and been caught smoking pot, and he wanted to know whether the marijuana destroys his brain. Right. Well, and they didn't know anything about marijuana. And the only thing was a young fellow in Israel had asked for a grant, and they had said no. So they came over, and that time we had isolated the first pure batch of THC. They took it, they smuggled it into the US. They didn't have a permit. And some of the research that was done at the beginning in the US was done with material that we had, and they funded our research for many years. And we went from the chemistry, isolation, structure, elucidation, synthesis of these compounds. And then we got into contact with biologists and pharmacologists, and we went into the biochemical or the biological effects of these compounds. And we learned a lot. We and many others started studying it. And we learned about the biochemistry and how it acts on the body and many things around it. One thing that was unknown for 20 years, even more than that, was what is the mechanism? How does it work? We thought originally it may be binding to some of the well-known receptors in the body and so on. Well, it didn't turn out to be that. It did not go along the known paths of biological work. So in the mid-80s, we saw that there might be a receptor, and indeed an American group found a receptor. That was in the mid-80s. Right. Now, receptors that are present in our body, and a lot of the compounds present in our body act through receptors, don't exist because there is a plant out there. Yeah. They exist because we produce compounds that activate them. So I said, okay, if there is a receptor, there should be compounds that activate them. THC by chance does the same thing, but it mimics something that our body makes. So we started looking for the compounds that are present in the body, endogenous compounds, if you wish. And we found in 1992, 1995, quite 20 years ago, more than 20 years ago, we found two compounds, completely different in structure than THC, but doing exactly the same. THC mimics the activity of these two compounds, endogenous cannabinoids, if you wish. And one difference, it acts for a longer period of time. It acts for a couple of hours. These compounds are not present in the body normally. They are formed when and when needed. And then they act. Let's say somebody is in pain. The body starts producing one of these compounds called anandamide. We called it anandamide. And then when it has worked or has done whatever it has to do on pain, it's broken down. THC stays around for a much longer time. Right. And we found these two compounds. One of them we called anandamide. Ananda in Sanskrit is joy, happiness, and so on. Right. We thought of giving it a Hebrew name, but there are not too many Hebrew names for joy. I mean, people here don't like to be sorrow. We wanted something that's happiness, extreme happiness. Right. So we took a Sanskrit name. Anyway, so these two compounds, now there has been a lot of work on these two compounds. Right. Because that's a new neurochemical system. It should have been discovered 50 years ago, but it was not.
So each individual person is producing happiness drugs for themselves for the short term.
Yes. Well, we thought that it does only that, but it does a huge number of other things. Right. The endocannabinoid system, which involves the two compounds we discovered and the receptors that were found, there are two receptors now, and the enzymes that synthesize them and break them down, and THC, all this is a system. Yeah. And this system is quite complicated, and this system is involved in a huge huge number of disease states. As a matter of fact, two well-known researchers at NIH in the US just published a review, and they said that the endocannabinoid system is involved in essentially all human diseases. Now that's a very, very strong statement. Never seen anything like that before. And the reason is that these compounds, the endogenous cannabinoids, regulate to a certain extent the action of the other neurotransmitters, or some of the other neurotransmitters in the body. And they have activities of their own. So they're very much involved in a lot of activities and in a lot of diseases. So there has been a lot of work on the scientific basis of these diseases, of these compounds and their actions on diseases. So we've been involved in many of these research projects with collaborators in Israel, collaborators all over. In the UK we have collaborators in the US, Canada, Italy, Spain.
Right. So you're now treating patients with cannabis products? Well,
that's one part of what we're doing. I'm not a physician, so I collaborate with clinicians looking at the activities of the compounds found in cannabis. Now, there are two main compounds. THC, that produces the psychoactivity, and so one should give very small amounts, and cannabidiol, which does not produce any psychoactivity and can be given at very high levels because it does not cause any major side effects. Right. And just as an example, the first time we did a clinical work with collaborators in Brazil in epilepsy, we found that after work on mice, of course, we gave a clinical trial. 8 patients got a placebo, so 8 patients got a material, and we could stop in about 50% of the patients, 4 out of 8, we could stop their epileptic attacks. 3 out of the 8 had much less, and 1, it didn't affect him at all. Right. And we published that, and I thought, well, now that there is some initial work, people will go ahead and look at these compounds on a much larger scale. I mean, as an academic, I can't do much more. Yeah. Nothing happened 35 years. Now, that's a shame, because we could have, or our observations could have helped a lot of children, adults. Now, parents in the US discovered that if they gave their children that had epilepsy, pediatric epilepsy, and it's a very, very unpleasant situation, if they gave them cannabis with high doses of cannabidiol, they could affect the epileptic attacks. Right. So the only place in the US at that time, 3 or 4 years ago, was, I think, Colorado. And they moved to Colorado and started giving them. And it seems to work. Right. So now there is a clinical trial on a large scale. Now, why did we have to wait 35 years? I mean, the hundreds, thousands of children could have been helped.
Yeah. Do you think it's to do with the taboo that cannabis is related to people smoking marijuana? Every country in the world has declared it illegal, although many countries are now making medical exemptions for the use of cannabis. Do you think the public's attitude needs to change and regard smoking it as one thing, but the actual cannabis as a drug should be totally separate, as a medical drug, should be considered totally separate and maybe legalized separately?
You're completely right. Yeah. There should be a complete separation, between medical cannabis and recreational cannabis. Yeah. Medical cannabis should be regulated according to medical rules. Yeah. If somebody goes to a physician, he doesn't tell him just take antibiotics, bye-bye. Yeah. He will tell him exactly what to take, what the doses are, how long he should take it, how he should take it, and so on. So in many places they think that medical marijuana is just a drug, take it and go away. No, it should be regulated according to well-established medical regulations. the medical principles. I mean, we've had that now for 200 years.
Yeah.
And
similarly, heroin is used illegally. Heroin's also used legally, medically.
yeah. So we should have a medical regulation, exact doses, and not everything is good for every disease. Cannabidiol is good, as I said previously, for epilepsy.
Yeah.
THC is good for post-trauma.
Right.
Things of that sort. Pain, both compounds are active. Cancer, I am not sure we can speak about it.
Yeah.
But that's the medical part. The recreational part is a social issue.
Sure.
Completely a social issue. If the population in a certain country thinks that it should be allowed, then okay, it should be allowed. It's a social issue. Populations have decided many years ago that tobacco is allowed,
Yeah.
although it's a toxic compound, a very
Caffeine.
toxic. Yeah, or alcohol, 50% alcohol in whiskey. Oh yes, it's allowed.
Yeah.
But that's a social issue. It has nothing to do with you had asked the medical people, or asked the medical people, should tobacco be allowed? The medical people will say no, but that's a medical decision. Things of this sort are social issues and have to be decided on a different basis. So one should see a complete separation.
Clinically, you've dealt with epilepsy. What other conditions are your medical collaborators using cannabis for at the present time?
Well, this is one of the problems. There haven't been too many clinical trials with cannabis, unfortunately. Medicine has developed mostly in the West, and a large part of it in the USA. But in the USA, there have been essentially no clinical trials. So while we have a lot of knowledge from individual patients, the medical knowledge from clinical trials is limited. And that's a shame, because physicians, rightly so, like to have the details of clinical trials well done from a reputable place, 100, 200 patients, and they can then give it to their patients with the knowledge, okay, I have the backing of whatever has been done previously. We don't have enough clinical trials. There are some. There is one clinical trial that was done in Israel some time ago against a disease called GVHD, Graft versus host disease. Unfortunately, some cancer patients have to have their bone marrow replaced.
Right.
Bone marrow replacement has to be done in some cases. It's not a pleasant thing to do. Quite a few of the patients are sick. Why? Because the body attacks the new bone marrow, and the bone marrow attacks the body, and the patient suffers. But it is a kind of an autoimmune disease. There are a lot of diseases in which the body attacks its own body, and that's an autoimmune disease. And it is well known that cannabidiol blocks autoimmune diseases. We have shown that in diabetes type 1, which is an autoimmune disease. So he decided to try it, and he gave large doses of cannabidiol to patients. And yes, it most definitely was very helpful in a relatively small number of patients, but it was definitely shown that it works. That was published, and they took a patent, and now they're developing it as a drug, and they're doing it on a large number of patients at the moment. So here we have another thing. There was work in Germany in schizophrenia, again with cannabidiol.
Right.
THC is dangerous to give to people with diseases of this, because they can have a schizophrenic attack.
Yeah.
But cannabidiol seems to help.
Right.
So they gave large doses of cannabidiol, and it most definitely helped. So I hope that as cannabidiol shows no side effects, chances are that it will be used as a drug, because the drugs that are used in schizophrenia, and many of these drugs are very efficient, but they cause side effects.
Yeah.
So here is another situation. But let me mention another clinical trial that we did, a small clinical trial, which I was involved a bit. It is post-trauma.
Right.
We did a small trial on post-trauma patients. We had about 10 patients or 12 patients that had different types of post-trauma. A few were soldiers, a few were women that had been raped, a few were people that were involved in traffic accidents. I mean, a different.
Sure.
And we found that it most definitely, THC in small doses, definitely helps, statistically shown that it helps these people, at least in some of the effects of post-trauma, like sleep. Yeah. These people are afraid to go to sleep because they wake up in the middle of the night and then they get whatever happened to them again. So they're afraid to go to sleep. Yeah. Well, they can go to sleep much better than without the drug. But there are quite a few other that have diseases in animal models that have been tried very successfully. And for example, diabetes type 1. Now diabetes, this type of diabetes, the body attacks the cells that produce insulin. Yeah. Now why the hell the body should do that, I have no idea. But it does it.
Yeah.
And then that happens.
Quite often in children it starts.
It starts with children. And diabetes type 1 is supposedly a pediatric disease. It starts with children. So we did work with animals, with mice that all had genetically that kind of disease.
Right.
They had diabetes type 1 that appears after 3 months or something like that. So we took and gave these animals cannabidiol at high doses, and only 30% of these mice got diabetes type 1 compared to 80 or 100% of animals that got it without cannabidiol. So as here we have the same mechanism as in human patients, then why not try it? It's the same mechanism, it's the same compound, it's something that is not toxic. We should try it. We need new drugs for diabetes type 1.
Yeah.
So there are a lot of things of this sort that one can go ahead and think in rheumatoid arthritis, another autoimmune disease. Yeah. We showed with a group in the UK, actually, in mice, that it most definitely acts. It's not simple, because we see that a certain dose it acts, then if we give more, it stops acting. It's called scientifically a biphasic effect. But it can be done, and new drugs are needed for rheumatoid arthritis, and the number of people suffering from rheumatoid arthritis is fantastic.
Sure, yeah.
And so we can go on with other things.
Is it fair to say that if somebody came along today and said, I've discovered a new plant, it's called yaba. This yaba, you can't smoke it, it's got no illegal part, but you get wonderful drugs from it, the whole attitude towards the chemicals would be different. And to a certain extent, we're looking at cannabis wrongly because of the illegality.
Well, you're perfectly right. But it has been changing slowly.
Yeah.
Now people realize that some diseases can be helped, especially if we look at individual components of the system, not take the whole thing and say cannabis, medical cannabis will help you. I don't know what is medical cannabis. Yeah. It's a mixture. It can be a lot of one thing, first time a lot of things. Another time there was a case of a mother that came to me and said, look, I have a child that has epilepsy, and I was given a bottle of contained a lot of cannabidiol, and it worked. Then the second time, when I finished that bottle, I got the same bottle from the same company, and I gave it to my kid, and she got all her attacks again. So I analyzed the two bottles, or the contents of the two bottles, and indeed one had a lot of cannabidiol and the other had nothing. Now, that's not the way to administer drugs. And that's one of the reasons physicians are unhappy with the situation, because they don't know what they're administering exactly.
Right.
It should be regulated. It's not such a complicated matter. It should be well regulated so that a patient or the physician and the physician should know what they are giving to the patient.
Yeah.
Neither the patient nor the physicians are happy when they have to give something with a lot of question marks.
Sure. Is the pharmaceutical industry worldwide taking on board the need for purifying drugs from cannabis?
Well, yes and no. Cannabidiol cannot be patented, so they are not spending money on cannabidiol, which is unfortunate.
Yeah.
But on the other hand, I'll go a little bit into science. There are two receptors, CB1 and CB2. Acting when the CB1 receptor starts to act, it causes the psychoactivity, and which is not desirable from a medical point of view, definitely.
Yeah.
The activation of CB2 does not do that. Activation of CB2 causes only, I would say, positive effects. It's more or less parallel to the immune system. And so companies, to the best of my knowledge, are developing compounds that act only on the CB2 receptor, which is seems to be compounds that act on the CB2 receptor alone, very, very promising, especially in inflammations, various kinds of inflammations. So I think that we shall have new CB2 cannabinoid drugs on the market shortly. I know that Roche, major pharmaceutical company, is developing compounds of that sort. There have been other trials with working on the enzymes and so on. So the companies are trying. I believe that we shall have cannabinoid drugs on the market within several years.
You mentioned Roche have done some trials, but are there any other companies around the world that are doing work on producing possibly commercially available drugs from cannabis?
Well, I know that some companies are developing new drugs. A company with which we were associated worked on a compound of ours that has osteoporotic effect. I mean, it works against the osteoporosis.
For thinning bones.
Yes. What happened was that was a completely different research that we tried.
Right.
It was not associated with cannabinoids. By the time we ended, it was part of the cannabinoid system.
Right.
What happened was, it has been published, seems to be well known, that women in the Mediterranean area have less osteoporosis than women in the north, in Norway, let's say. And the reason for that was thought to be olive oil.
Oh, right.
Okay, if it's olive oil, then we looked at the main constituent of olive oil, of oleic acid, and it was not active. Then we thought maybe it's a derivative of oleic acid.
Right.
And so we thought, what are the possible derivatives? We synthesized a few compounds, and my colleague Itai Bar, the late Itai Bar, tested it, and he found that one of the compounds was extremely potent in mice against osteoporosis. And we started thinking, well, something's interesting here. The compound we synthesized, we looked for it, and it is found in bones. And it is found in bones, and women after the age of 50 or 55, when their reproductive system doesn't work anymore, then they get osteoporosis. Most women at that age and later have osteoporosis, not a serious one. Sometimes they have serious osteoporosis, sometimes not.
But the bone density is less.
The bone density goes down. Exactly, we saw that happening in mice.
Right.
We saw that if we neutralize their reproductive system. After a few months, they get osteoporosis, very serious osteoporosis. So at that point, we started giving them the compound that is present in the bones. We synthesize it, of course, the amounts in the bones are very small. We synthesize it. And yes, not only did we stop the osteoporosis, we actually saw that the bones go up.
Right.
And this particular compound blocks the enzymes that break down the bones. Now, it turns out that this compound is closely related, chemically and biologically, to one of the endogenous compounds, the cannabinoids.
Right.
So we started looking around, and it turned out that there are quite a lot of compounds in our body that are similar. And a lot of academic groups are looking at these compounds. There are about 150 compounds of this type. And those that we have looked into, and other people have looked into them, most definitely show activity. A couple of them are active in pain. A couple of them are active in appetite. Appetite is endocannabinoid system is extremely important in appetite.
I think it's been used in terminal cancer patients, hasn't it?
Tell you about cancer patients, that's a sad story. Anyway, it's in appetite. If we take, so to complete this story, these compounds that act on osteoporosis are endocannabinoid-like compounds, and the company is developing a derivative of these compounds is the anti-osteoporotic drug.
Right.
So here we can expect something happening. Now, you asked about cancer.
Yeah.
Here it's I don't find the right word, it's a sad situation. Thousands of patients are using medical cannabis against their cancer, and some of them report that it works very well, whatever that means. There hasn't been a single clinical trial with cannabinoids against any cancer. Now, that I don't understand. I mean, it's being used.
Yeah.
People say that it's effective. There are
It's anecdotal evidence, but you need clinical trials.
So people use medical cannabis against cancer without knowing what to do with it. Do we need a lot of THC? Do we need a lot of cannabidiol? We have done work with in one of the hospitals, as well as here with some of my neighbors that work on cannabis. Most definitely, both THC and CBD and many of the other, as I said, 100 compounds that are closely related to cannabis act on cancer cells, So we're working now in mice. But there is a difference. I mean, humans are not mice.
Yeah.
Until it's done in humans, we are not there. Now, why for having governments or whoever bodies that do work done anything in cancer? They say it's okay for cancer. What does it mean it's okay? I mean, I don't know what it is.
People want results.
Yes, and we don't have any results in humans.
Right.
Any explanation for that? The answer is we have no explanation why there have been no clinical trials. Now, governments don't usually initiate clinical trials. Yeah. That's true. But this is a very special case. Companies don't do it, and we have anecdotal evidence that it acts. So there should be somebody maybe our Ministry of Health, doing the clinical trial.
Has the impression that the government, to a certain extent, is scared. All governments seem to be scared to grasp the nettle of separating the illegal use and the legal use.
Yeah.
And maybe it's political lobbying that's needed.
Probably they don't understand it. So we are trying now. There is a initial clinical trial starting at Hadassah. There are a few initial clinical trials starting in Tel Aviv. We found a donor who is going to support the work in Tel Aviv and glioma.
Right.
And we have found
with
another
brain tumor, glioma.
Yes.
Glioma.
And there are some other brain tumors, and maybe we're going to work on a brain tumor in another hospital. But it should not be done in that small way. It should be done in a major way. I mean, okay, somebody should spend so many millions to find out whether the anecdotal evidence is correct and whether one should use for this type of cancer a certain mixture or one of the compounds, for another type of cancer, another mixture or another pure compound. This we should know. We should have known about that 10 years ago.
Maybe we need to get the politicians to watch Live Doctors, and especially this interview, and you never know what could happen after that.
Completely right.
You've mentioned before that you know of many people who are using cannabis products medically. Where do they get them from? Do they get them from a clinician, or are they getting them illicitly?
Well, in Israel at least, we are rather liberal in the way it's done. About 15 years ago, the Ministry of Health decided that it is willing to give or to allow patients to get cannabis for whatever disease they had, but under certain regulations. A patient cannot apply for a permit himself. Only a physician can apply for the permit to get cannabis for a patient. He has to say more or less, we have tried other things, nothing helps as much as we want to. I believe as a physician that he should get cannabis. His request goes to the Ministry of Health. The Ministry of Health then decides whether to approve it or not. There are physicians there that decide on that. And so it slowly developed, and there are about 26,000 or maybe 28,000 patients that get cannabis for their as treatment for their diseases. That's a lot for a small country. And every single case has been evaluated. Every single case, not for every disease. It is allowed more or less for pain, especially cancer pain. It's allowed for some gastrointestinal diseases. It is allowed for post-trauma. It is not allowed for psychiatric diseases, not for schizophrenia, not for anxiety, deep anxiety and things like that. But if there is a special case, let's say asthma. Asthma is not on the list. But some people say a puff of cannabis stops my asthma attack. Then if a physician sees that this is true, then he will be allowed. I had a patient like that recently. So it is quite flexible. And so we have, as I said, 28,000 patients that get it. And I think this is okay. It's not too well regulated because the companies that grow the material, they do not always follow medical requirements. But it is slowly being changed. And the ministry at least says that medical cannabis will ultimately, within a year or two, be supplied in pharmacies with, according to all the medical rules. Let's see whether that happens.
Have you any idea as to the situation in the United States?
Well, the United States is a mixed thing because every single state has its own rules. For the entire United States, it is illegal. But many states allow medical cannabis with different regulations. It's not the same regulation. Colorado has more liberal regulations, others have less liberal regulations. And a few of the states have also allowed recreational cannabis. But that's, completely different.
As well.
It should be completely different. So in California, I think there is always a problem there because there is a clash between the state and the national level.
So it would be possible for patients in certain states in America to receive cannabis on a medical basis.
That's true, and in some places...
And again, they'll be going through the physician.
In some places they go to a state that allows it.
Yeah.
But it's a strange situation that if you stand on one side of the state border, it's okay. On the other side of the state border, you go to prison.
Yeah. Thank you again. Thank you.
My pleasure.